we're ready?
No, no,
Not yet? Okay, good. Hi, Catherine. I'm Seppi Shine. How are you? Nice to meet you. Hi.
Ayako.
Ayako, nice to meet you,
Nice to meet
Seppi.
you.
Thank you for participating this evening and for your work in the community. Oh, so you want me to go to you and then her?
Yeah, why don't you go
Okay,
me
never mind.
and then I can hand it over. I can
Perfect.
hand it over to her.
Even better.
Did you bring your laptop with you? And Ally Chef.
I'm going to move your... Sean, I'm going to... Can you
here.
put this underneath the...
I'm gonna give it to Tim.
Yeah.
It's actually a good turn for the rain. I thought it was sure. Let's hear it. You know, the moment we said it's gonna rain, it could be 2 weeks out. It doesn't matter.
Exactly. Like, let's just...
Do we want
Hello, everyone. Thank you all for being here and for your commitment to our community. With all the resources and tools that we have, there's no reason at all for people to still be getting HIV, but that is not the case, which is why tonight's efforts are so important. So I thank you for being here, and I want to thank Mayor Pro Tem John Erickson for really spearheading this effort, and I'm going to turn it over to him.
Thank you so much. Thank you so much, Mayor Shine. I'm John Erickson. I'm the Mayor Pro Tem, or if you don't speak Latin, Vice Mayor of the City of West Hollywood. But it is such an honor to be here with all of you, all of these leading experts, on really something that we've been championing here as a city for quite some time. Specifically, I want to call attention to the long-standing efforts that the City of West Hollywood has played in the fight against HIV and AIDS since the early days and continuing on, especially with our HIV Zero campaign and then early access advocacy around PrEP and PEP. And furthermore, this conversation just doesn't start with us or end with us. It actually is a continuation of council members past and present. And I also want to add on board members and commissioners past and present, some of which who are in the room and who have been a part of this struggle and fight for further advocacy. People like Jimmy Palmieri, Stephen Davis, Todd Hallman, and everyone else who has been here for quite some time making sure that this medication could be out here. And so without further ado, I'm going to turn it over to my colleague, Chelsea Byers.
Thank you. Thank you all so much for being here tonight. I want to recognize staff and the members of the boards and commissions who showed up to participate in this conversation, as well as all the experts and community members. I just think this is a really fabulous example of what happens when folks with lived experience are the ones who are making policy, and I'm really grateful to you all for helping lead this charge. Just a few words about tonight's hearing before we get it all kicked off. Why are we here? A quick glance of Senate Bill 159 and a reality check from John Erickson will be happening. We want to give a big thanks to Senator Scott Wiener and his staff, to many of you who know worked really hard to pass SB 159. The bill was a great first step. We really need to continue this work to ensure that everyone who should be on PrEP can get it, and that anyone who needs access to PrEP is aware of what it is and how to get on it within the 72-hour window. A couple quick things to keep in mind. This hearing is not a solution to all problems. We have attempted to include as many voices and communities as possible in this room tonight. We should always hold open a chair for those who aren't here. This will not be the last conversation, and hopefully other cities, counties, communities will also initiate conversations on what's happening with access to PrEP and PEP and how to improve and expand access to PrEP and PEP. We'd all be better if West Hollywood was the lead, more people followed.
And I'm going to turn it over to our amazing Senator, Ben Allen.
Here we go. Hey, everybody. It's so nice to see you. I just want to obviously say such good evening to Mayor Shine and to Mayor Pro Tem Erickson, all the distinguished council members. Let me just start by saying what a great pleasure it's been to work with all of you. We've got some great legislation done recently, and it continues to be such a fruitful partnership, and I just really appreciate the great working relationship I have with the city of West Hollywood. I want to thank you so much for inviting me to be part of this discussion today. One of California's most vibrant, diverse, and accepting communities. It's also been a real leader in the fight against HIV. Of course, that's largely because few cities have been so acutely impacted by the AIDS crisis in the 1980s as West Hollywood was. We know the story of the founding of the city, 1984. I know John's there. Obviously, it was of many respects founded as a safe space for the LGBTQ community, particularly gay men at the time. Of course, it also, as a result, meant that the city tragically suffered a devastatingly high number of deaths from the disease. And I remember this so vividly myself. My mom, some of her very, very close friends died of AIDS, and as a young boy, I remember going with her to visit with them and to help nurse them as they were suffering so terribly under the yoke of the disease. It's something that really left a mark on me, and looking forward, of course, to the memorial that we're building together. Yeah, but anyway, nonetheless, through its history. Sorry? Oh, sorry. Okay. Yeah. Obviously, through its history, the city and its residents have shown such strength and leadership in meeting the public health crisis around HIV/AIDS head-on, from becoming the very first government entities worldwide to provide social service grants to local AIDS and HIV organizations, to more recently, the city's groundbreaking HIV Zero strategic plan. It was passed by the city just a few years back, I think in 2015. So, obviously, Thankfully, HIV is no longer a death sentence for those who contract the disease, but we do know, because we do have the tools to prevent its spread entirely through the use of the antiviral medications PrEP and PEP. Though we know, unfortunately, the CDC's latest figures project that only about 25% of the at-risk population that could benefit from PrEP are currently taking the medication. And many of these folks are simply unaware of, or they're unable to access PEP after a potential HIV exposure. Of course, West Hollywood's been particularly impacted given its demographic, but let me be really clear, every Californian who's at risk of contracting HIV should have easy, accessible, and affordable access to these life-saving drugs, regardless of their address, their sexual orientation, their gender identity. Now, the legislature took a great first step along that path in achieving that goal when we passed SB 159, which was back in 2019, to allow local pharmacies to provide PrEP and PEP to qualified patients without the need for a prescription. That was really important. But we know that there's much more work to do to ensure that this law is better implemented. I actually was just in West Hollywood touring with the chamber, went to a pharmacy and learned about some of the challenges associated with actually making this access a reality. We've got to make PrEP and PEP more widely available. We've got to help make sure that at-risk communities are better educated about their options for preventative care. So just as it has throughout its entire history, I'm just proud that West Hollywood has continued to take such a leading effort, a leading role in this effort, including by convening tonight's informational meeting. You just know that you have a willing and engaged partner in me, in my office, in this fight. I really look forward to working with each of you, so many friends around the table, to better promote equitable healthcare outcomes for our residents. And so with that, I just want to thank you for allowing me to say a few words. I look forward to hearing directly from impacted community members over the course of tonight to learn how we can better serve their needs. Thank you.
Hi everyone, I'm really sorry that I can't be there with you in person. I'm Scott Wiener. I have the honor of representing San Francisco and Northern San Mateo County in the California State Senate. I also authored Senate Bill 159, which got the ball rolling on pharmacists providing PrEP and PEP without a prescription, and I'm now authoring Senate Bill 339 to make sure that that law is fully implementable. I want to thank West Hollywood for your work and leadership around so many issues in a million different areas, and I love working with West Hollywood and your staff and your city council, but particularly around HIV issues and understanding that HIV is still with us. This is still, people are still getting infected, and we need to do everything in our power to give people the tools that will help keep them negative. And we know that if you are consistently taking PrEP, you have almost zero risk of contracting HIV. And there are too many barriers to people obtaining PrEP, and giving pharmacists the ability to dispense this without a prescription will remove significant barriers. When we passed SB 159, it was groundbreaking. We were the first state to take this step. But unfortunately, during as part of our very complicated and contentious California legislative process, we were forced to put some restrictions on the application of the bill that in retrospect have made the bill very hard to implement. Other states like Colorado and Utah have gotten out ahead of us and have not put those obstacles into their law. So I introduced SB 339 this year, working in collaboration with HIV advocates, with Quality California, with our Pharmacists Association, as well as several of the major pharmacy chains to try to make it easier to implement this law. And so the two major things that we're doing is, first of all, making sure that pharmacists can get reimbursed for the time that they take to do this, because there are various things that pharmacists have to do as healthcare providers to provide PrEP or PEP, and we want them to be compensated for that. The second is that in SB 159, we limited the supply of PrEP that pharmacists could provide to 90 days, at which point a person would have to automatically transfer over to a physician's care. That has been an obstacle as well, and so SB 339 will loosen that up and allow a pharmacist, consistent with CDC guidelines, to continue to provide that care and provide PrEP beyond the 90 days. So I'm optimistic that we can make this better and make this law fully implementable so that we can dramatically expand access to PrEP. We know that there are some people for whom making an appointment with a doctor, which might take a month or two, or just going to a doctor, can be an obstacle. As fantastic as our doctors are, but people walk into their neighborhood pharmacy all the time, often multiple days a week. They know the pharmacists, they are comfortable in that scenario, and so we want to make sure that people can take advantage of those relationships and expand access to PrEP and put an end to this epidemic once and for all. So again, thank you for your work, and I look forward to continuing to work together.
Thank you, Hernan, and thank you again, everyone. It is now my honor. Oh, and just in case you have questions or comments, there will be time after the presentations. Moya, if you want to raise your hand, is in the back. They have amazing little speaker slips. You can do that. It'll be formal-ish, and then if you want to come up and speak at the mic, you can do it. It's okay. So go see Moya after our amazing presenters. But now we're going to have Dr. Aaron Celius from the Maroon Society present.
So now the volume is good. Good evening, everyone. My name is Dr. Aaron Celius. Thank you for the introduction. I am the Director of Research and Strategy for Maroon Society. Over the past 7 years, Maroon Society has been evaluating progress made on the HIV Zero initiative. And tonight, I'm just going to talk about three things. I'm going to talk a little bit about the HIV epidemic in the city of West Hollywood. I'm going to talk about some of the progress made on the 4 goals, as well as demonstrating why greater access to biomedical interventions, specifically PrEP and PEP, for highly impacted community members continues to be a priority for the city of West Hollywood, is a priority for the county of Los Angeles, and should be a priority for all highly impacted areas across the nation. Let's see. So next slide, please. Or I can just talk about it. Okay. Oh, okay. So I will continue. So what's unique about the HIV epidemic in West Hollywood is it is 99% male. Primarily gay, bisexual men account for 99% of the individuals living with HIV, as well as new diagnoses. Next slide, please. What's also extremely unique about the city of West Hollywood is the high prevalence of HIV. It's 11.2% of all men living in the city of West Hollywood are living with HIV, so that's more than 1 out of 10. Compared to Los Angeles County, which is 1% of all men are living with HIV, and it's higher than nationwide as well, which is 0.8% of all men. And so that makes West Hollywood very unique, and it is what helped encourage City Council as well as community members to always take an active role in making sure that HIV is a priority and making sure that support services are available as well as preventative services, which is what brings us to the next slide, which is the HIV Zero initiative with the 4 broad goals. The first being to increase access to healthcare, competent healthcare services for people that are highly impacted, as well as those who are living with HIV. decreasing HIV diagnoses, decreasing HIV-related disparity, as well as reducing stage 3 or AIDS diagnoses. And over the past 7 years, the city has done tremendously, making progress toward all 4 of these goals. Now, go to the next slide, please. So, how have they done that? Well, they've done that, if you can click it one more time. They've done that with a coordinated effort between social services providers. So the city staff, the way the city works is that they fund social services and different services to make sure that people living with HIV have access to all the needs that they may have, whether it's medical, social support, transportation, housing, food assistance. I'll just continue even though the slide's not there. And so that also includes biomedical interventions. Each year, the city's social services department spends about $7 million on these social services contracts. These are for people that are living with HIV, as well as the community at large. And that's all right. That screen is fine, you can leave it there. And what I'm gonna talk about tonight is access to biomedical services, including PrEP and PEP, which the city also funds. I assume everyone in the room probably knows this. There may be people at home who don't know this, but PrEP is a once-a-day pill currently that someone takes that makes it extremely difficult, almost impossible to acquire HIV if they are exposed. The scientific rates are between 95 to 99% efficacy if someone is adherent to taking this once-a-day pill. That's pre-exposure prophylaxis, or PEP. PEP, or post-exposure prophylaxis, next slide, is a medical regimen that someone would take if they were exposed to HIV that can also help prevent them from seroconverting or acquiring HIV. Next slide, please. So, as I had mentioned, the city has made tremendous progress on all 4 goals. This one is remarkable. This is, at the beginning of the HIV Zero initiative, there were about 60 new diagnoses every year of HIV. As of the last reporting period, it's down to 22. So that's cutting it by 300%, new diagnoses. And this has, next slide, this is ultimately the work of coordinated efforts from city staff, social services providers, to address the needs of community members through biomedical interventions. And I mentioned PrEP and PEP. I didn't mention treatment as prevention, which is if someone is living with HIV and they are adherent to their regimen, they can reduce their viral load so that there are only trace amounts and they cannot transmit HIV. And so those 3 things, treatment as prevention, PrEP and PEP, have been an effective tool to reduce HIV diagnoses, as well as what we're seeing here are the modes of transmission. And at the beginning, about 95, click it one more time, please. 95% of all new cases were based on sexual exposure between men. In the last 4-year period, that is down to, I think it's 82%. So we've seen a reduction, and that has to do with one of the second goals, which is to reduce HIV-related disparity. And the way that the city defined that is making sure that no one group has a higher propensity to acquire HIV than anyone else. And so seeing this reduction among men who have sex with men is demonstrative of that progress. Next slide, please. So each year, over the course of this evaluation, we also conducted a biannual survey on stigma. And part of this was to understand people's awareness of PrEP and use of PrEP, among other things that had to do with stigma for people living with HIV and people that were highly impacted by HIV. And so the community always had really high awareness in the 90s, as you see at the beginning of the evaluation period, up to 100% by the last survey that we conducted. And this was just before the pandemic took hold. And you also see that usage went up between the 2 periods of time. We would like to see usage higher, but we're still moving in the right direction. Next slide, please. Also on the previous slide for pre-exposure prophylaxis, there were no statistically significant differences by race. What we have found, though, is that there are significant differences when it comes to awareness of PEP, or post-exposure prophylaxis. And so these two slides really continue to demonstrate why it's important to increase education and points of access for people to obtain biomedical interventions, including PrEP and PEP. Next slide, please. So, please click it one more time. So what we see in the city is that while there has been tremendous progress, as you can see, diagnoses are down, there continues to be racial disparities in who is acquiring HIV, where men of color represent 28% of the population. They account for 64% of all new diagnoses. One more click, please. By comparison, white men in the city represent 72% of the population, but only just above a third of all new diagnoses. And so it's all moving in the right direction in terms of numbers going down, but racial disparity continues to persist even at a small level, which we also see at the national level and the county level, but just making that aware. In the next and last slide. What we see here is data that was pulled from centers of excellence as reported by the Department of Health, Los Angeles County's Department of Health. And so what we see here as well is that the continued racial disparity, where among new diagnoses of HIV, 18% are among white community members, whereas PrEP prescriptions, they account for much more than the population that they're receiving many more prescriptions for PrEP than they are for HIV diagnosis. And so what that means is if we were looking at this from an equity standpoint, we would want to see a one-to-one relationship where 18% of the prescriptions also corresponded to 18% of new diagnoses. But we see that that's not what it is. Whereas for people of color, they represent 82% of new diagnoses, but they're only receiving, over the past 2016 to 2021, almost 7 years of the program, 71% of prescriptions. And so this is all demonstrating why greater education and points of access continues to be needed, and perhaps more navigation for highly impacted community members of color so that they can catch up and make some of the gains that we've seen among white community members. And leave it at that. Thank you.
All right, thank you so much, Doctor. We are next going to go to Jeffrey Rodriguez, who is the Director of Community Programs at the LA LGBT Center. He is joining us via the World Wide Web, so we'll give that a second. And we're going to start with Sergio Velasquez over here, who is the Clinic Director for APLA Health. So Sergio, would you mind going first? Thank you.
Hi, good evening, everyone. So I'm going to go first, just to give Jeffrey some. I'm going to go first, just again to give Jeffrey some time to catch up and make sure everything's working right on his end. So again, my name is Sergio Velasquez. I use he/him pronouns, and I am one of the clinic directors for APLA Health. Specifically, I am at our Out Here Sexual Health Center. I also supervise our PrEP navigation program. So a lot of this is cases that I see every day, cases that my PrEP navigators see every day. Next slide, please. Sure. So in this presentation, we will cover health disparities and PrEP uptake among priority populations. So some of this is what Dr. Celis has already presented. The data that we have is a little bit more national, but it should still give a pretty clear picture of where the gaps are in care. We have a couple of case studies for PrEP patients. So with Jeffrey and I working directly with the population, we kind of see what a typical patient who needs PrEP or PEP looks like and what challenges they face just coming into our doors. A lot of that, you'll notice, has to do with finances and cost. We'll also present some special cases and challenges with access to PrEP. And lastly, we also have a case study for someone who comes in and needs PEP. Next slide. So I want to start off with, again, just some data to give you some background. We've made major improvements in HIV prevention. There have been substantial gains in PrEP use in the United States. So for data reported in 2020, as Dr. Celis said, about 25% of people for whom PrEP is recommended were prescribed it. compared to only 3% in 2015. The CDC also estimates that new infections fell 8% from 2015 to 2019. But however, there still remain health disparities among priority populations. HIV still affects some groups disproportionately. These groups are also most likely to be affected by social determinants of health, such as lack of affordable health services, low health literacy because they've never been able to access these health services, poverty, lack of transportation. Sometimes, folks are working multiple jobs and can't get to a clinic. And there's other systemic barriers as well. New HIV infections for Black and African American people are over 8 times as high, and for Hispanic Latinx people are over 4 times as high as those of rates of new HIV infections among white people. Next slide, please. So I'll hand this over to Jeffrey if he's joined us.
Jeffrey, you need to unmute.
I can continue. Sure.
So there he is. Okay. We missed you, Jeffrey.
Sorry.
All right, so are you watching the presentation?
I don't see it on my screen. Yeah, it's not being shared.
We are not sharing it with you on Zoom.
Okay.
Were you hearing? Were you listening?
I can't hear. I just now started hearing you folks. I couldn't hear anything before that.
I can. Yeah. Of course, yeah. So to go on with more data, PrEP uptake is not equal. CDC data from 2020 shows that there are significant gaps in PrEP care. So Black and Hispanic populations report the lowest numbers of PrEP uptake despite having the highest rates of infection. To give you some specifics, only 6% of all PrEP eligible Black patients and only 16% of PrEP eligible Hispanic and Latinx patients received a prescription. Similarly, these gaps exist with trans women. Trans women are at high risk for HIV infection due to a lot of the same factors that I presented before, but also due to transphobia in healthcare settings, housing instability, racism, unemployment. Data shows that 4 in 10 trans women in 7 major US cities are HIV positive, and only 32% of HIV negative transgender women reported using PrEP, even though 92% were aware of PrEP. Next slide, please. So again, this also reiterates the points that Dr. Salas made. Most challenges to PrEP access exist not because people don't know about PrEP, but because they don't know where they can get it or how they can afford it. Next slide, please. So again, I have a couple of case studies of patients that we typically see at our community health centers. The first one, the patient is 30 years old, Black and cis male. He knows about PrEP and wants to start the medication in order to better protect himself against HIV infection. This patient makes about $60,000 per year and lives in West Hollywood. He is privately insured, but has a high deductible and high copay. The patient also wants to know what is available to him that will help him afford his PrEP, including any PrEP-related costs from his visits, his labs, and any copays at the pharmacy. Next slide. So what assistance is available to this patient? Based on income, residency, and insurance information provided, this patient qualifies for the PrEP Assistance Program, PrEP app. This program will cover the remaining costs of a patient's PrEP-related services after their insurance has been billed. This includes medical visits, HIV, STI, and PrEP initiation screenings, STI treatment, and even PEP. The patient will also likely qualify for a manufacturer's copay coupon card. This will cover pharmacy copays depending on what they're prescribed, and up to a certain dollar amount per year. But even with a patient like this, where we have solutions, there can still be potential challenges. For this patient specifically, depending on the patient's insurance provider and their policy, the patient may only be able to access generic emtricitabine tenofovir, DF, generic Truvada. We are seeing this more and more, where health insurance policies say the patient can access PrEP, but they limit it to this one medication. So if the patient, is contraindicated or has other comorbidities where they can't take this medication, they then have to submit a letter of medical necessity to their insurance provider in order to gain access to an alternative like Descovy. Next case study, the patient is a 25-year-old Latinx trans woman. She heard about PrEP out in the community and wants to know if she can access this medication. The patient makes about $40,000 per year but doesn't have pay stubs, lives with a roommate in West Hollywood. She's uninsured and does not know where to get health services because she's never been able to access any services. The patient wants to know where she can access PrEP and if she'll still have to pay anything out of pocket. So what assistance is available to this program? To this patient, like the last one, this patient, based on income, residency, and insurance information, will qualify for the PrEP assistance program, PrEP app. For uninsured patients, PrEP app will cover the cost of their medical visits and labs. It'll also cover some vaccinations and some medications, including for STI treatment. The patient will also likely qualify to enroll into the drug manufacturer's patient assistance program, which will cover the full cost of the medication if they qualify. And again, still, there are potential challenges that exist. The patient will need a little bit more support in applying for this assistance. Because she does not have pay stubs, they will need to work with an enrollment worker to submit an income verification or self-employment verification affidavit. The manufacturer's patient assistance program also usually takes about 1 day to process. If the patient, for example, came in for PrEP on a Friday afternoon, we have to make sure that this is processed before their office is closed at 5 p.m., or else this patient will be without PrEP through the weekend, and the earliest they might get approved is Monday. There's some special cases with PrEP access, so not everything is very straightforward as these last patients were. A patient may have confidentiality concerns where they can't use their insurance. For example, we see plenty of patients who are under the age of 26. They're not out to their parents. They want to start using PrEP, but they would have to go through their parents' insurance. Many undocumented patients are also hesitant to access the PrEP assistance program because they fear that this will negatively affect their public charge evaluation, even though it won't. Again, as I already mentioned, a lot of private insurance companies will limit access to PrEP to one medication, and so if a patient needs an alternative, they will have to submit a letter of medical necessity through their provider. This letter oftentimes needs to be submitted with every prescription, so this is kind of just adding steps to the process where this process really shouldn't be this difficult. Moving on to PEP, again, the biggest challenge with accessing PEP is more so that people don't know about PEP or where they can even access this prevention tool. So our PEP case study, a 24-year-old Latinx cis male has unprotected sex with a partner of unknown HIV status on a Thursday night. The young man's not on PrEP and has no health insurance. After speaking with a friend, he decides to seek out PEP. However, because of his schedule, he knows he can't make it in until 2 p.m. the next day, so Friday. He knows he needs PEP, but he's unsure of how this is going to impact him financially. He read that there are sometimes 2 medications used for PEP and that each one of these is expensive. He's worried about also the cost of his provider visit and the labs that he might need. So there is still help available to this patient. They're eligible for the state program to, again, cover the cost of PrEP medical visits and labs. Due to the urgency of the situation, the patient can be enrolled under a temporary access period, so they'll get 30 days of access to this program without having to submit income or residency verification information. The patient may also need to be enrolled in the manufacturer's patient assistance programs. But again, there are still challenges. So since the patient arrived at the clinic at 2 p.m. Friday, the application to enroll the manufacturer's assistance program must be submitted and processed before the program's office is closed. For PEP, this is even more of a challenge because as Dr. Sellis described, PEP needs to be started within 72 hours of HIV exposure. And so this patient really doesn't have the weekend to wait for this application to process. Also, some clinics, emergency departments, and urgent care facilities are able to offer their patients what's called a PEP starter pack that gives them about 2 to 3 days worth of PEP medication while they get to a clinic, while they get assessed, and maybe work on their access to the medication. If the clinic this patient went to does not have PEP starter packs, they don't have access to this. The state's PrEP app assist program also offers immediate access to PEP, but again, this usually requires someone to work with them, doing the process yourself. While the patient can enroll themselves, it can be a little cumbersome and lengthy for the patient. That's all I have for you today on challenges for PrEP and PEP access. Thank you.
All right, thank you so much. And now we're gonna go to something even more sexy and fun to talk about, and that's policy. You can laugh at that. We can laugh at this a little bit. But it's my pleasure to introduce our last two set of speakers, and then we're gonna open it up to questions. I know we have Shane here, as well as some other people, so get ready if you haven't. And thank you, Jeffrey. Sorry about the tech issues, but welcome to Zoom. And so we're gonna introduce Ayako Mishita Ochoa. Okay, I did okay. JD, the co-director of the Southern California HIV/AIDS Policy Research Center, and then Catherine Cohen from the UCLA Law Center, Center on Reproductive Health Law and Policy. So take it away.
Is that good? Can people hear me? Okay, great. Thank you, everyone. My name is Catherine Cohen. I use she, her pronouns. And as John mentioned, I'm a staff attorney with the Center on... Oh, it's not? Oh, okay. Is this better? Thank you. I'm a staff attorney at the Center on Reproductive Health Law and Policy at UCLA Law. And we can go to our next slide. This has kind of been touched on, so I won't spend too much time on this slide, but this is just additional numbers about disparities in PrEP use and access, particularly by race, showing kind of that similar gap that Dr. Celius has shown previously between the percentage of PrEP prescriptions and percentage of new HIV diagnoses. And then the study on the bottom is looking at disparities in PrEP uptake, and this is also likelihood of uptake among people on Medi-Cal, so low-income people. Particularly wanted to demonstrate that this isn't a matter of likelihood of adherence or uptake, but again, like other panelists have said, it has to do more with not knowing where to go, not lack of information or lack of willingness to go through the protocols to stay on PrEP or PEP. We can go to the next slide. So I'm going to give a brief overview. Take this out. I'm going to give a brief overview of some of these laws, building on some of what Senator Scott Wiener has already said. First is Senate Bill 159, the reason we're all here, which, as has been said, allows pharmacists to prescribe PEP, and then the initial bill was 60 days of PrEP to patients, has some requirements that have served as barriers in implementation of this law, including that pharmacists are required to ensure that a patient is HIV negative and provide counseling. So I was doing testing and counseling, two things that pharmacists might not typically do or might not have reimbursement protocols for in order to actually get compensated for something other than delivering the medication. It also, the initial law had a limitation of the 60-day supply and only 60 days of the supply every 2 years. And so continuing the care is a barrier that we have heard. And then in addition, requires the pharmacists to help somebody find a more permanent source of PrEP care, including a list of physicians or clinics or providers. This is, again, a service that pharmacists might not typically be doing or be reimbursed for. There was also some important pieces of this law having to do with insurance coverage, prohibiting insurance companies from requiring prior authorization or step therapy to practices that are often used to limit the costs, but can cause delays in access to medication or for people to be using medications that might not be as effective for them.
and also a prohibition on allowing a pharmacist or a pharmacy benefit manager to kind of block access to PrEP and PEP, so kind of getting rid of those refusal abilities for this medication. Another piece of important legislation that impacts this is SB 409, which came about during the COVID public health emergency in order to expand access to various testing through pharmacies, and also authorizes pharmacists to provide CLIA waive tests, one of which is HIV testing. So pharmacists can now do HIV testing and expanded their scope of practice in that way. Also, Senator Wiener mentioned some of these already, but wanted to flag some other states that had similar laws that have done things a little bit differently than California and can kind of explore some of those existing barriers. One is Colorado, also authorized pharmacists to prescribe and dispense, also blocks step therapy and prior authorization requirements, and requires health insurance companies and carriers to actually cover pharmacist prescribing, not just the drugs, but also the consultations. And so dealt with some of those reimbursements issues. Oregon went about this in kind of a different way. They had a piece of legislation that allowed the Board of Pharmacy to approve certain drugs for pharmacists to prescribe and dispense, and then the Board of Pharmacy later approved for those for that practice PrEP and PEP. They have a 30-day supply and testing requirements as well, but they do also have reimbursement for pharmacists' time spent prescribing, and also required insurers to cover PrEP and PEP without prior authorization, and also regardless of whether or not the pharmacist was in network. And then Senator Wiener talked about this a little bit, but wanted to just have up here some of the information he talked about the current piece of legislation that's in the state legislature this session, Senate Bill 339, as it addresses some of the barriers that we identified in our study. Two he already mentioned is increasing the length of time that somebody could access PrEP through a pharmacist. Just blanketly expands to 90 days, but then also allows for beyond 90 days if certain requirements are met, which have to do with the pharmacist kind of case managing and keeping track of the records of the person accessing PrEP, and so can really expand that continuation of care. Also has the reimbursement issues requiring insurance companies and Medi-Cal plans to reimburse pharmacists for the time that they are spending counseling and testing. And then one that wasn't yet mentioned too is broadening the definition of PrEP under the state law. It was previously in the legislation a very specific medication that was included and was covered. This piece of legislation would expand the definition of PrEP to any drug that's been approved by the FDA to reduce the chance of contracting HIV, and so it could allow for pharmacist administration of injectable PrEP and other different forms of PrEP as well. And then I'm going to pass over to my colleague to talk more about the study.
Hi, everyone. Ayako Miyashita Ochoa, she, her pronouns. I am representing the Southern California HIV/AIDS Policy Research Center. I work in collaboration with our community partners at APLA Health, True Evolution, and the LA LGBT Center. And we are joined on this project by so many partners that are very knowledgeable and very engaged on this topic of pharmacy-delivered PrEP and PEP. So you'll see at the bottom here quite a few partners on there. You know, we couldn't have done this without the pharmacists. And that's really what we have to say about SB 159, period. What we realize is that here in the state of California, we love passing great laws. But we all know that that's not the end of the road, right? So what we decided to do was a research study asking pharmacists to give us their perspective on SB 159 and to tell us what are the key barriers keeping them from being able to do this. And so what I'm going to share with you today are hot off the press findings from this study. I will say that this study also has a component that I think Catherine will be talking more about in the future related to medication abortion and hormonal contraception and emergency contraception. So hold that thought. That's also coming. But for today, I want to share with you what we've really found out about PEP and PrEP in pharmacies. So I will always begin as someone affiliated with UCLA that we want to honor the Gabrielino and the Tongva people's ancestral relationship on the land that we learn, teach, and engage on. And again, a thank you to pharmacists. So as you can see, what we started here in October was a recruitment period to ask pharmacists across the state to engage in an online survey using Qualtrics, one of our platforms that we often like to use. And we did a lot of different kinds of recruitment. So you should know that we had pharmacists pounding the pavement. We had study coordinators sending out mailers. You know, we were pushing really hard to get as many people as possible. We also, in the era of online surveys, had to use a lot of different techniques to try to eliminate duplicates and bots. So at the end of the day, next slide, we received survey responses that we were able to validate for over 900 pharmacists. Okay, 919 to be total that were included in this particular study. What we found were that we had representation from across the state, not obviously all jurisdictions as you can see, about 29% from LA County and 23% from San Francisco. That's always to be expected in California. But you'll see here that among the different types of pharmacies represented, we had community pharmacies making up the largest share at 43%. And this is really important for the reasons that I think some of our panelists have already touched upon, the importance and essentially the role of community pharmacies in this work. Next slide. What we found was that of all the pharmacists that we talked to, only 11% worked at pharmacies that are implementing this bill, okay? That doesn't mean that's a generalizable statement of the state of California, but it means that of the over 900 people that we talked to, right, only 11% worked at a pharmacy that is implementing SB 159. The things that I want you to focus on here too is that on the left-hand side there, you'll see that 92% of pharmacists had heard of PrEP and PEP. So they're knowledgeable, aware, know about PrEP and PEP. 96% stated that they feel it's important, right? That this is an important thing to do to be able to provide PEP and PrEP. And 72%, that's not a bad figure, I will tell you the truth in terms of awareness about the law. 72% had heard of SB 159, but look here at the bottom. Only 41% reported being confident in their ability to prescribe PrEP. So what happened? Why are there only 27% of pharmacists reporting that they received training on PrEP and PEP dispensation, right? Their ability to prescribe. And that's because COVID hit, right? At the same time that all this is happening, we're also seeing an increase in the role of pharmacists in delivering health services. And I think that's a really important contextual statement to be made, that pharmacists play an important role as very highly educated healthcare providers in our system of care. Next slide. So why, right? This is the big question, and I think everybody already knows in this room the whys, but I think it's important to put some numbers to it. So 53% of pharmacists said that allocating staff time for PrEP services was difficult, given that the medication, right, which is done on a reimbursement basis, is covered, but the services are not paid for, okay? And there's quite a bit of services that have to happen in the context of dispensing PEP and PrEP. So, in terms of the non-implementing pharmacies, these are the folks that are working in pharmacies that are not doing SB 159, right? The three things that they listed sort of at the top are not having enough time, not having enough staff to add this new service, no insurance coverage for the prescribing piece, and then low perceived demand among clients. There's a demand question here, and a lot of you have hit on that as well. Last but not least, 42% reported that they felt the 60-day limit is not enough. Why would this be the case? And I think that some of our qualitative work that's still underway gives us a little bit of insight into that. And it's that pharmacists are not regularly in the business of providing referrals to providers, to healthcare providers to follow up, right? We're asking them to do something that is new. Secondly, I think it's because, as you heard from Sergio, you have to enroll people in programs, not just PrEP app, but also in, right, copay programs. And these processes are not simple. Are we asking pharmacists truthfully to do that for all of their patients? I just heard right before we started this panel, someone that said, my pharmacist is so busy, they don't even have time to talk to me, right? So imagine we're asking pharmacists to take this burden on again without enough payment for services. Next slide. So the good news is this, right? We sort of were concerned that pharmacists perhaps might have conservative thoughts or ideas or feelings about PrEP and PEP, and that's not the truth. That's not what's happening here. If you see at the top, right, there's complete disagreement with the fact that it would be in violation of the pharmacist's religious beliefs or that it would be endorsing a lifestyle they don't support. That's the good news. The not so great news, or the news that we sort of expected but wanted to confirm here, is that, right, there's a high level of willingness to prescribe, but much less, right, a feeling of confidence in knowledge and much so less confidence in ability. Okay, next slide. So here's some really quick policy recommendations stemming from this particular study. It's everything that has already been stated. And that's the wonderful thing about research. We get to come in afterwards with the numbers to prove what you already know and what you have already experienced. So reconsider the 60-day limit. Easy. That's what 339 is trying to do, right? Ensure payment for pharmacist-delivered services. Easy. I say easy to pass the law, not easy to implement. Advertise training programs for pharmacists seeking to implement 159. Guess what? Our two core partners are delivering training programs, right? So it's happening, you all. It's happening. But the question is do pharmacists have enough time, enough, right? Enough capacity to take on this training? Next slide. I wouldn't be a researcher if I didn't tell you what our strengths are and what our weaknesses are. So really quickly, I just want to say, this is a large sample. We're so very proud of the partnerships we built to be able to get this many pharmacists to answer this survey, right? We have a multidisciplinary team. I'm a lawyer by training, coming out of the closet, but we had pharmacists, social scientists, we had all kinds of people at the table. We had people with lived experience. We had people, members of our team that literally went into their pharmacy to try and get PrEP. And so that's a strength of ours. But again, this is a convenience sample, meaning that you can't say this is the truth for all of California, for all pharmacists across California. And also the last piece is that this is about pharmacist perspective, so it's not necessarily representative of all pharmacies. So that's the little nitty-gritty. Next slide. The conclusions are fairly simple. Implementation's lagging, right? We have some work to do, and some of that work is talking about how we streamline training and initiation requirements. Obviously, increasing reimbursement and payment, that's going to help. But, you know, in our qualitative work, what we're finding is that pharmacists are telling us we don't even know where to record patient notes on our platforms. It really comes down to having protocols in place so that pharmacists know how to do this work in their workflow that they're engaged in day to day. And that's an important piece to consider. Next slide. So I just want to say this is, you're hearing it first in this hearing. We literally just printed out the 2-pager that's out on the table if you haven't seen it, as well as the infographics from this study. It would not have been possible without all these people who were a part of our study team as well as part of our circle and of course our funders at the California HIV/AIDS Research Program. So thank you so much for allowing us to share this information with you today.
Can we get a round of applause for all of the presenters? Leave it on, you're gonna have to ask questions. Thank you so much, everyone. And you said something right out of my mouth, is that I actually went to Hernan and said, hey, I'm doing a secret shopper campaign because I'm trying to get on PrEP in the city, and we have a lot of pharmacies, a lot of great pharmacies, Capital Drugs, which has been there for so long, and at the beginning, fight of HIV and AIDS, and none of the pharmacies would do it. They were like, we could, but I just haven't taken the training, all the things, and so eventually I went to Planned Parenthood. That is my day job, by the way. And I got on, but I went to every pharmacy in West Hollywood, an LGBTQ center, if I will, and I couldn't get on a life-saving medication. And I look at privilege and access. I'm a white cisgendered gay man with insurance, good insurance. And if I couldn't get access, what did that mean for someone else that couldn't get access? So that really started a lot of the impetus for why we could do this. Called up Scott Wiener and said, hey, your bill isn't working. And now here we are at. And so we're gonna open up to questions. I did forget to give my gender pronouns. They are he and him. I apologize. But I also wanted to acknowledge that the city of West Hollywood is also on unclaimed, unseized territories of the Gabrielino Kizh peoples. So I want to make sure I make that acknowledgement and apologize for my miscommunication there. But I'm going to turn it over to the chair of our Transgender Advisory Board and a person I consider a hero to start us off with the questions. Shane?
Well, thank you very much, John Erickson, for the support and continuing this effort, especially within the city, and the important work that we are all doing here, the research we've all done, and especially the client work. APLA has actually been a big partner in some of my own personal stories, so thank you so much for showing up. It's really important that, this can sound like a lot of information for folks that may not know how to read, but I'm really good at kind of walking you across the bridge. What this is really boiling down to is a lot of red tape that's unnecessary when it comes to this medication. Whether you're gay, whether you're trans, whether you're straight, it doesn't matter. This medication can serve to save your life, and we need to have access to it in the same way that we have access to Plan B. You can go to the store, you can buy it for $50. There isn't blood work that's attached to it. There isn't all of these things that are attached to it. Now, granted, I understand the medication itself has some certain requirements, but there's some certain red tape that is causing so many different dynamics and communities to not have access to this life-saving medication. I can tell you myself needed this medication in the last year. I needed PEP, and I didn't have access to it properly in the city, and I had to go around finding the resources because even the emergency room themselves didn't quite know what to do in the situation. Now, as a transgender man myself as well, there was more intersectionalities in my own story that happened simultaneously, and that's why PrEP access is so important. Now, in my own personal work that I've done, in my work experience, I also came across so many patients that lacked access for not the typical reasons that you would think. It wasn't just because they were low income. It was also because they had access to health insurance with a high deductible and they were unable to make the payment. It was also because of the red tape that was created where they were able to get that first distribution of Descovy, but 3 months later when they were trying to get blood work done so they can get that refilled, it was unable to find appointments and things that would end up being all of these barriers for these patients, and cost was a big issue for these patients. Now, depending whether you are at the top of the threshold or the bottom of the threshold, there's so many different barriers depending on what your intersectionality and representation is. Now, for instance, John Erickson does have seemingly a lot of privilege, but he himself recognizes he was unable to actually get access to this with this idea that it was here in West Hollywood, but it really doesn't exist. Now, with pharmacies, we've got to find a way that we can support them, and that's why these questions are so important, is asking how do we as a city support you, and what can we take in legislative actions to actually make a difference. Because with what's happened with Gilead in 2019 and the copay cards that have cost and all of the red tape and all of these programs just to get one single patient into care, sometimes they have to do 5 applications and it can take hours and hours, and if there's one thing wrong, that application has to be restarted. You have to think about what that's actually like for a patient. They're not going to want to come back, and we have to think about compliance as well. Someone who's dealt with 2 weeks of calling back and forth with a provider, hey, I need to get this insurance thing worried about, they're not gonna wanna come back in 3 months because they just dealt with 2 weeks of a headache going back and forth with that provider, and they just don't wanna do it anymore. So once their Descovy runs out, that's when they'll decide maybe to go off the medication itself. Now, another issue that patients will come to find is, again, access. We don't have as many queer providers as most folks think that we have access to, and nor do we have access to the pharmacies and the education that folks are claiming. It's the confidence as well. We may have those folks that know the medication exists. We know folks have gone through some forms of training, but there's something there that's missing, that's lacking, that's making them not feel confident. And what can we do to support those pharmacists? So that's why these questions are really important today, for you to ask these questions so we can take this change make it into action, and really do something, because PEP saved my own personal life. And I didn't even think, as a trans man who lives within the binary and who has a wife, would ever need to have this access to this medication. But unfortunately, I had a very terrible incident, and it did save my life. It prevented me from contracting HIV. And ever since that moment, I've become so passionate about understanding how this medicine is just beyond us as a queer community. Yes, it's starting here at the work, but this is medicine for the entire world. Whether you're gay, straight, bi, trans, whatever your intersectionality is, HIV is a risk for you. There's different demographics of what that risk looks like, but at the same time, this medication needs to be removed with this red tape, and we need to find ways for us to really support you. So what those questions are, please ask those today, because that's where we're gonna find a way to support you. And this conversation is gonna continue. It's just starting, but I do really wanna say thank you to John Erickson, the entire city of West Hollywood, city staff, Yvonne, Derek, and Hernan. I want to make sure to give you a shout out as well for actually continuing this work, because what we do here can truly change the world. And we can know that as we are growing and we are changing, we are looking at other communities, seeing what we're doing here and being inspired to ask for that access as well.
Thank you so much, Shane. All right, here we go. Okay, so Jimmy, did you want to say anything as a member of the Human Services Commission? Is Moya here? Why don't you go on up there?
Hi, I don't know all of you. My name is Jimmy Palmieri. I'm a member of the Human Services Commission. And Doctor has given us a lot of information over the last few years that we're absorbing. The barriers to get this is shocking to me right now with Mayor Pro Tem Erickson's information. I don't know. I always think I live in a bubble and that everything is going to be fine here, and West Hollywood, is a panacea for everything. But my experience has not been that. I mean, I have a great doctor who had me on Truvada as PrEP, and before it went generic, put me on Descovy as PrEP so that I didn't have to fight that. And it worked out for me. But I have a friend that lives next door. Has a great job, has great insurance. His doctor, this is true, said it's just like having HIV if you take these meds. So it's not, you're not really beating anything. And that made my head spin. Maybe you can approach that. But his doctor said these pills will fool your body into thinking you have HIV, thereby preventing him from even wanting to take these pills. So that was a barrier that I came across here. And I did want to get your opinion on that, or your information on that.
Yeah, maybe if you could talk about how the stigma around PrEP and PEP originally kind of, clouded some people's willingness to maybe take it, and what we have done or can do in what Jimmy was saying.
Sure. Thank you for those comments, Jimmy. So I've never heard a medical professional say anything like that. That's not borne out by the research or the clinical trials and people's experiences with any of the clinical research that I've looked at. So it sounds like that doctor was uninformed, to say the least. Throughout the years where we've been looking at stigma, at the beginning, there was, when we asked, well, what are some of the barriers that you're experiencing to considering PrEP? You're a candidate, what are the barriers? And slut shaming and the stigma associated with PrEP was a real barrier in the earlier days of the evaluation. And so that was more of a stigma that people were experiencing and expressing, that they didn't want people to find out that they were using PrEP for fear that people would judge them for whatever that meant to them.
No, that's good. Did anyone else want to chime in on this, or you feel?
That's good.
Do you have questions, people? Moya? Okay.
We have Armando Macias, followed by Elnaz Panbeci.
Come on up, Armando. Or we can have the mic.
Hello. First of all, I just want to say it's really awesome to be in a room full, especially with you. Oh, sorry. Can you guys hear me? Okay. It's really awesome to be in this room with you guys and hear how passionate you guys are about, bringing awareness to PrEP. My name is Armando. My pronouns are he, him, and I'm here representing Mr. I'm the marketing director. And if you may or may not know of Mr., it is a telemedicine platform that offers free online PrEP and STI testing across all 50 states, including DC and Puerto Rico. In California alone, we enroll approximately 600 patients each month, majority of which are Hispanic, Latinx. Nationally, we have over 150,000 patients. We are successful for many reasons, but the main reason for our success is that we have eliminated barriers to accessing and adhering to PrEP. We've eliminated the time-consuming and sometimes uncomfortable doctor office visits, which you guys had discussed, that sometimes arise, and brought the required lab testing to patients through our at-home testing kit. In short, we created a convenient and stigma-free experience, as you described yourself as well. Moreover, we handle all the back and forth with insurance and leverage those various patient assistance programs to ensure patients have no out-of-pocket costs, which sometimes that's quite a barrier. The online process starts with a health questionnaire, followed by a virtual doctor visit, and then patients can choose from our at-home testing kits or in-person testing, whichever is more convenient as well. Our focus is on the LGBT community, for we are part of the community. However, 18% of our patients don't identify as LGBTQ, as you stated as well. It's for everyone, as including the straight community as well. But we serve the underserved and those on the other side of the spectrum. Our services is completely free, and it's not just for those who are uninsured. In fact, 70% of our patients are insured and 30% uninsured, and it's those that are insured that allow Mr. to support those that are uninsured. And that's Mr. Online. But as many of you may have noticed, Mr. is here in West Hollywood, San Francisco, and 4 other cities across the country. Our storefronts are pharmacies that will not only be able to support those seeking injectable PrEP, but also offer access to PrEP in California as per SB 159 and SB 409 as well. And we'll be able to connect them to continuing care online through Mr. So I just want to thank you for today, and also we have the opportunity to end new HIV infections this generation. So thank you guys.
Thank you. And you're at Westbourne and Santa Monica Boulevard and San Vicente and Santa Monica Boulevard, and you'll be open soon.
Yes, this quarter, so please come by.
There you go. One question before we go to another question is I wanted to throw a curveball at Catherine because she's brilliant, but we're seeing a lot of religious exemption challenges to access to not only mifepristone, if you're following, it's the medication abortion pill. That lawsuit ruling is going to come out any day now, taking away that pill from the market, and even in pro-choice states like California. But they're not stopping there. They're actually coming at religious exemptions for PrEP and PEP. And maybe if anyone wanted to take this question, what types of fears do we face legally, policy-wise, from an activist standpoint, from a medical standpoint? I would love to kind of get everyone's feeling about that.
Yes, thank you for that question. Unfortunately, I think this is a place for fear. Sorry, I don't often have good news. But typically and traditionally, there have been pretty broad exemptions for individual pharmacists, individual doctors, any sort of individual medical provider to not have to provide care that they have a religious or moral opposition to. Typically, I believe at least in California, they're supposed to refer you to somebody who can then deliver that care. So it shouldn't be like the entire pharmacy doesn't provide PrEP, but an individual provider. And a lot of this is played out around Plan B, so kind of similar attitudes and beliefs that can play into that. There is a bunch of unfortunate cases working their way through the courts right now. There is, in particular, a case in, I believe it's also in Texas, of an employer who doesn't want to comply with the Affordable Care Act's requirement of to cover all preventative services that applies to PrEP medication, and so is trying to claim a religious exemption to having to provide PrEP in the insurance plan that he provides for his employees. So he's not a healthcare provider, he's an employer who pays for the insurance for his company. And that's in a not good district. There are a couple of, well, the way that the Texas district courts decide who gets the case, you can pretty much choose your judge if you file a case down there. And so unfortunately, it's probably not gonna lead to a good outcome. I think this is kind of part of a broader trend that we're seeing with the courts where the federal courts have gotten a lot more conservative in the last administration, and the Supreme Court too seems kind of willing to say that your religious beliefs means, or religious liberty means that you can impose your religious beliefs on other people. You know, I think here in California, we are going to hopefully continue to have strong protections. The current administration and legislature are very supportive of increasing access to sexual and reproductive health care, including HIV prevention medication. But unfortunately, we're probably going to end up with this system sort of similar to what we're seeing in the abortion context, where it's a state-by-state variation in access.
What I find concerning is that that particular litigation also calls into question the U.S. Preventative Services Task Force and the work of experts, public health experts, to be able to provide recommendations around care. And so the piece about the recommendation for PrEP is that making it a grade A recommendation triggers a lot more protections in terms of people's access, and they are attacking that particular task force and the work of that task force and trying to say they're not authorized to make these kinds of decisions. And I think that it follows the trend that we've seen, which is the attack on science and the attack on experts who have spent their lives, dedicated their lives to doing this research and having this knowledge. So that's what I do find concerning. I'm with Catherine, like, oh, I don't want to alarm you, but let me alarm you. It's just sort of a reality of our moment.
Yeah, thank you. I would like to say just a few things that are maybe unique. I think if we do see a rise in people asserting their right to not provide service, I'm not so fearful in this area, but in areas outside of LA County or Los Angeles County, I think that's going to be an issue. What we've seen in West Hollywood, because there are so many competent providers, we see people coming here for services because it's such an inviting area. And so I think possibly requesting more funding for these service providers may be one great response. I know that there's some providers, I know Men's Health, they have gone into other areas outside of the city to make sure that people have access to these types of resources. It's concerning to me that there's so much misinformation out there to proliferate stigma. And so there are people who otherwise would take advantage of these services aren't going because they think it's going to be just like experiencing HIV, like Jimmy's neighbor had mentioned. And so the people that need access to these things the most may have the least likely opportunity to get accurate information. And then if they do have the information, it's alarming that you had such a difficult time getting on PrEP here with all the access and information that you have. And so I would just continue to advocate for greater navigation services and perhaps more of that within the city and the county as a collaborator for greater access to these biomedical interventions.
Before I go to the next question, did you want to say something? Okay.
So, I mean, we have to call it for what it is. It's strategic. We are strategically being attacked at all sides through the healthcare system, through our justice system, through our lawsuits, whatever they're taking to erase the access that we took 50 years to actually gain. They are systematically going in a different way than I think I've ever seen folks go before. They're going to school boards, they're going into our health system to actually take away our access and the thriving society that we have made as LGBTQ plus folks. This building, this city that we live in, they are actively looking at the building blocks and the foundational things that we advocated for these years and systematically pulling them away. So it's our time to truly look at what's actually happening systemically as a whole and what we can do to provide the resources for you so we can get rid of these red barriers and these tape so we can fight back at the same energy they are pulling away from us. So that's what I'm seeing going on.
Yeah. All right, Moya, next question, please.
Yes, next we have Elnas Panchebi, followed by Mac Bajeri. Please go ahead and use the
Usually I'm too short for these things, but I guess I'm good enough. My name is Elnaz Panbetchi. I'm a pharmacist. I've been managing CVS pharmacy for the past 10 years. I've managed stores up to 4,000 scripts per week and small stores. I worked at independent pharmacies. I was actually excited. I was one of the first few that actually got certified for PEP and PrEP when it came out. And my vision was always, I've gone through the entire convoluted system, healthcare system. I've seen it all. I've seen it from a CVS or retailer perspective and how shorthanded we always are. Rate of overturn is anywhere between 70 to 80%. We're usually understaffed. Corporate usually gets us to not have enough staff because at the end of the day, we're the pharmacists that care and we provide. And I was always the pharmacist that wanted to stay in the forefront to take care of my patients. What I realized is that there's, as you said, there's a lot of red tapes for retailer pharmacies. I'm not a big fan of corporate pharmacies. I think they don't have the patient's best interest in mind. And in the independent realm, there's so much going on as far as reimbursements that these folks that can't survive. So my vision had always been to be an independent consulting pharmacist where it takes away special interest as far as working in a pharmacy or pushing drugs, but rather being a prescriber. So I figured out a way of being a consulting pharmacist, and it just actually came into fruition the past couple of months. And after COVID, I had the vision, vision came into being, and I figured out a way that we could actually go around the 60 days limit that we could give PrEP and PEP. There is a California law that we could actually bypass it. You just have to be smart and strategic, as you said. And I would like to help city that I actually live in. I have a place here. I have worked at the pharmacy here, the CVS on La Cienega and Santa Monica. I've seen a lot of folks and how much they suffer because we have some pharmacists that don't really care. They just want to push. They just want to get you out of their doors as fast as they can. And I hope that I could work and collaborate with you guys, some of the findings that I've had, and maybe even have an independent pharmacy that works in the city and have some pop-ups. Why do we have pop-ups for clothes and everything that is luxury in a sense because it's not necessarily needed? But why can't we have pop-ups for independent prescribers? I remember a couple of years ago when I had exposure I had unprotected sex, I came here, and that was the first place that I came to get my STD testing because I couldn't find anywhere else. I had insurance, I had accessibility, I have education. I could have gone anywhere, but this was the best place that I found, and I wasn't even a resident back then. So if I could give back to the citizens and anyone that's working in, that's living in not only in this city, but anyone that doesn't have access, it would be an honor. And I would be more than happy to share anything that I found over the years, over the past 2 years, I can't say, but working as 10 years as a pharmacist for you guys.
There was a question in there, and I'm going to pull it out.
Okay.
Because the question is how do we get pharmacists in this new world that we kind of live in now, who are playing almost a doctor role instead of providing just medication, something that you are trying to bridge over. But in terms of the study that you presented, how could we do, or what tools are needed for pharmacists to take on these extra care steps, to do these things, or maybe they can't, and what barriers do you see, or anything like that?
I could answer that too.
Okay, well.
I mean, sorry, go ahead. I just wanted to, sorry. I'm too excited, sorry.
I think you're the right person to answer it, actually.
Thank you.
Yeah. No, just from the policy landscape, the expanding scope of services that pharmacists can do is something that, from the policy context, is made really clear here in California. We've just moved towards that. Recognizing that we have really, talented, invested, highly educated people in pharmacists was the first step, and that we have already done. The next step really is to think about then how do you bridge, exactly as you said, the role of what pharmacists have been historically with this new vision. And it starts with some of the most basic building blocks you can imagine. So I'll give you an example of sitting in on a qualitative interview. Again, companion study, results will come out soon. I can't tell you when exactly yet, but of a pharmacist that says, I really want to do this. I've even got the space to do it. I've got the will to do it. But my platform that I'm using, these are the data systems that we have. I don't even know where I can put notes in, the kind of notes I would need to keep to be able to get paid for this service. It really just comes down to having a playbook. So what is that playbook? What are the resources to build infrastructure, especially within community pharmacies, independent pharmacies? Those are some of the real big questions that I think we're going to have to tackle.
Oh, okay, thank you. So SB 159 is not for pharmacies, it's for pharmacists. And in the state of California, as strict as the Board of Pharmacy is, it is very liberal as far as it allows the pharmacists to be independent providers if given a collaborative care agreement. So basically, if you go to a physician and say, hey, I'm a pharmacist, I'm a pharmacist, so you don't even have to go to a physician, and you could provide up to 60 days of PEP or PrEP. But past that, you could go to a physician and say, hey, let's do a collaborative agreement together. I know this, like for me, I could do chronic, what I'm doing right now is chronic care management, diabetes education, HIV prevention, and HIV prescription for post-exposure. And why don't you just collaborate with me? If the physician feels like, not feels, but if you collaborate with them, you could prescribe anything. So my whole goal has been, I became a pharmacist to take care of patients, not to be a special interest pushing drugs for CVS, Rite Aid, Walgreens, or anybody else that wants to make money and live in their yachts. I'm sorry, no offense. For whoever lives in their yachts or is corporate, I apologize. But why don't we treat pharmacists as actual healthcare providers? And we can. It's just that most pharmacists are scared. Most pharmacists don't know about it. And to be frank and honest, working for a big corporate company, they scare you and they kind of bully you into not doing it. Because if you do it, then you stand up against them. And their whole thing is that we will buy you out. There's no way that you could survive. There's no way that you could survive in this big, wild world, because we're so big that no matter what you do, we're always going to come and buy you out. So that's
Please, yes.
I just want to make the clarification that what I think at the heart of SB 159 is really not having to require a collaborative practice agreement, period, right? It's not forcing that upon pharmacists, that pharmacists themselves are prescribing. And so I think that is the direction. And I think, collaboration is not a bad thing, but you can't always force it, right? And so for the pharmacies that don't have the collaborative agreement, should they be kept from doing this important work? And the answer is no, they shouldn't be.
Sergio, when we were talking for this, and thank you so much for everything, I appreciate it. I'm going to ask a question before we go to the question. Yeah, if you want to, thank you. Yeah, you can stay wherever you want. You're wonderful, or you can go back there. It's fine. Yeah, you're great. Give me your card at the end because we're going to be best friends. We talked about how the moment you get on PrEP, those 60 days, those 90 days are so critical, and we're asking pharmacists to do a lot. But now how do we make sure pharmacists know providers that can get the patients into systems of care that are continuous, right? How do we make sure a CVS pharmacy, and I tried to go to a place that rhymes with Margit, and they said no. But how do we get people in Tennessee right? Let's just say a city like Tennessee that maybe APLA Health doesn't exist in, we know it doesn't, but how do we make sure pharmacists who have no clue about these things know providers like you, and how critical is that connection to care for long-term stability?
Yeah, so one thing that I didn't touch on during my presentation is the importance of retention in care. So we could talk about adherence all day long, but adherence really means nothing if you don't have that retention. So that those first 60 and 90 days after someone has been prescribed and starts PrEP are really important, because we want to make sure that the patient returns for their 3-month follow-up, their lab work, so they can get the next set of prescriptions, they can keep going on their PrEP care. For a pharmacist that provides that, the first 60 days of medication, in order for the patient to stay on PrEP, it really is important for them to have those referral networks to their providers that they know are not just PrEP competent, but are also not going to discriminate against the patients because they want PrEP. I can tell you a lot of our patients come to us for their PrEP care only because their primary care physician, they don't really feel has their best interests in mind when it comes to PrEP care. And so for these pharmacists, it's really important to build these referral networks, to really build these collaborations across, the pharmacy and providers in the area. It doesn't just have to be one. It could be, community health centers, federally qualified health centers, anywhere that can really connect with the patient. Because at the end of the day, also, what I didn't touch on for PrEP care is that for many of our patients, PrEP is their first step into healthcare. And so from PrEP, we are able to connect them into primary care services, behavioral health, substance use disorder services.
Moya, next question, please.
We have Max Bagari, followed by Jimmy Palmieri.
Thank you so much for giving me a few minutes to make it short and sweet. To complement what Elna said, my name is Max Bagari. I'm a pharmacist. I own and practice a pharmacy walks down the street on Beverly Boulevard. Since 1992, when I did my rotations at the Cedars-Sinai HIV unit, I became a community advocate for in West Hollywood, for people of West Hollywood, including the HIV community. The reason I'm here, actually, it's just one simple thing. We are doing community service at a small pharmacy. We're not doing business like Elnaz does at CVS. I am trained, my staff trained to dispense PrEP. We stock PrEP. In the past year and a half, we had only one walk-in to get PrEP. It's just, I was just wondering if you guys talking of access, this study that you talked about was very, very nice. Just explaining exactly, people don't know where to go, what to do, but we are right there. So where do we get these people coming in? Do we have to put a big ad on the store or what? We are part of the community. I think we should implement something to just kind of put this chain together. It seems like we got some sort of disconnect somewhere.
It's on. Okay. I think that I've mentioned a few times PrEP navigators. I think that those are individuals that would bring someone to a pharmacy like yours if they didn't have access themselves. Right. But I think that it's not as ubiquitous as something like Plan B, that people don't recognize that A, it's available, and B, that they can get it for free or a very low cost, and they can get it from a pharmacy. And so I think that there's just going to be a gap in that education and awareness. And unless there's funding associated with it, it's going to be very difficult to get more than a few people in the first few years, I imagine.
Okay. All right. Well, I think that was my main thing to say. If you have any comments.
Well, I'm thinking for a solution to help you, it does seem like a little bit of a marketing issue as well, but simultaneously, if we could possibly create some sort of database so we can actually do some sort of outreach with the city saying, if you're an inclusive PrEP-trained pharmacist, reach out to us, so we can actually add that to the city website so folks can actually access it, because I can tell you myself, when I was trying to find services, the marketing wasn't there, and it was a big gap, is the marketing issue, yeah.
That's exactly what it was.
If you would, Yvonne over there. Spoiler alert, I'm doing an item that will adjust our entire city website to update our social services to reflect these things as we continue to navigate this process. And we would love to feature your amazing work.
Sounds good.
Would you like to say?
I'd like to just follow up with, I think that also there should be a little bit more collaboration with the county Department of Public Health. I know that they initially funded 14 what are called PrEP centers of excellence. Some are represented in this room tonight. And I think that along with that website, I'm not sure how many people access it, but I think that a point where people can go that would be interested in PrEP and PEP, it should have the ability to do a search for those providers. And I know that that was a component of an earlier version of the website. I think that adding the pharmacy component would be a fantastic contribution.
I mean, when the program started, we thought we're gonna have people line up getting PrEP, but it seems like the awareness, the connectivity, the access, the announcement to people, like knowing where to go, where to get it, how to get it. I think it's easy to get the message across to people who really need it, especially through a hotline or some sort of a marketing school.
Do you have anything in your location that says we also provide PrEP and PEP?
Well, we don't have anything outside on the window.
I mean, when people walk in, is there anything physically that they could see?
Patients that I serve quite a bit of HIV medications, but we don't have anybody else who is not part of my family. So just it's nice to just, if I can do anything, collaborate with anyone in the city level.
Go talk to Yvonne. We're going to get connected. Sorry,
so
Yvonne. Next question, please, Moya. Thank you.
Up next, we have Jimmy Palmieri, followed by Eric Matos.
Hi, I didn't want to forget this. It's important to me. Jimmy, can you hear it? Can you hear me? I'm sitting there in shock with my colleague on the Trans Advisory Board and with Mayor Pro Tem Erickson about their barriers in the ability to get PEP and PrEP. I mean, as a commission, we think we have this pretty tight, and this is mortifying to me and my colleague. As easy as it was for me to get PrEP, when I got home, I looked at my after visit sheet. Whoever looks at those, I never do, but I did this time, and the code was high-risk homosexual behavior. Okay. I don't care.
Should we talk monkeypox again, Jimmy?
I don't care about it. But if there's someone that when we've talked about stigma ad nauseum, actually, if someone is afraid, if their parents don't know, if their parents are religious, whatever the reason, and there are a million reasons, we all know this, I had Derek and David Juni call the provider and say, what's up here? They assured them that this was the insurance code that was required. So that's a barrier. I don't know that you can change it. I just wanted to throw that out there. But it was a barrier then, and it's going to be a barrier because I just pulled it up on the internet, and it's still required as far as that goes. PEP pop-ups, yes. PEP has always been problematic for us. But social marketing campaign for PEP and PrEP, as we've had for condoms. We've been distributing more than 250,000 condoms a year for my duration on the commission. And we have signs in the windows of all of the stores that give the condoms away for free. So I think his name was Max, says he has a sign up. If you do put together a comprehensive list of those that are freely exercising this and put their names on the city's website and put a sign in their window, people would know, okay, this is a safe place, I can go here, I don't have to be afraid. And I think we can help a lot of people that way, but it's a social marketing campaign, and you know the amazing results we've had with condom distribution.
Definitely. And we can't all forget I'm sorry to bring up the word monkeypox, or what do we call it? Mpox, sorry, Mpox. But remember when everyone was trying to find a vaccine for Mpox, and you all essentially had to sign the form that said you're a high-risk homosexual behavior, all of the stuff that you were doing in order to get vaccinated to prepare yourself, and you had to bring your PrEP and PEP to to come. Did you want to say anything? Sorry, you look like you're about to. Oh, okay, there we go. Okay, Moya.
Next up is Eric Matos, followed by Kyle Berner.
Good evening. Thank you for doing this, Mayor Pro Tem Erickson and panel and city staff. I have a quick question for the policy folks, and that is, how can we look to integrate this pharmacy education into our university system to where we're front-end teaching our pharmacists and our pharmacy techs and these public health experts about this bill and how it could impact the access to PrEP and PEP. So that's my first question as a matter of policy. And the other thing I really want to touch on is something actually Mr. Palmieri said, which is the public access and social marketing campaign, having those centers identified in communities so that people know, hey, I can actually walk into a Target pharmacy and get a PEP or PrEP prescription. But my next question is, how can we look to implementing this on a community level? I actually grew up in a very small rural community in Central California. You don't have to go to Tennessee to have a lack of awareness to PrEP and PEP. It's right here in our beautiful state. And you know, I actually personally didn't even know that PrEP or PEP existed until I joined an LGBTQ kickball team here in the city of West Hollywood. So how can we implement that on a community scale right here in West Hollywood? Thank you.
Perfect. So if we create this list and we're actually really extensive with it and we open it up for folks and we keep it updated, we're gonna make our PrEP and PEP navigators' jobs the easiest thing in the world, because what they're gonna be able to do is then take their client, look at their local home address and find a relative pharmacist that's within that area, and that's where they're gonna send that off, and building that relationship. So identifying these pharmacists that are inclusive is really important so that we can pinpoint it, and having a website that these CBOs can really access easily and unfettered so that they can find these pharmacists rather quickly. Because again, it comes down to building that patient profile and setting them up with the care that they're gonna actually show up in the 3 months and get the blood work and actually show up to the pharmacy and pick it up. So we're trying to create a cohesive setup for them. And again, having that access and creating that database, I think, can take a patient navigator's job down from 2 hours to maybe 15 seconds because they can just type that in.
And we have patient navigators for abortion services as well. So you can see the similarities, which is why women's rights are everyone's rights. You see the connections. I'm speaking to a crowd, but Catherine.
That's what I was going to say, actually. Yeah, so I was going to say something similar. I work a lot on reproductive rights and abortion access, and I think a lot of the ideas that folks have been talking about tonight for public education are things that the state and the county are doing right now for access to abortion and birth control and emergency contraception. And so I think that could be a model, right? We have in LA County, we have a safe haven project for abortion access. A big goal of that project is public education. We have the state that has created, it's like abortion.california.gov or something like that. That is, it sounds like kind of a combination of a lot of the things that folks have been talking about here. Navigators helping you figure out, where is the best place to go based on your location and what specific kind of care you need. Also just education. I think just like the base level education about the medications is valuable. And also a provider list, right? Something like that. And so I would love to see the county doing something similar, and I just want to echo what has been said before of these are overlapping issues, right? Like the attacks on abortion are not siloed over here, and they're going to let LGBTQ people and PrEP and HIV medications be. The folks who are attacking these things see them all as interconnected, and so we should be working across these issues to expand access to all of these forms of care.
We have one more question, and we need to wrap up.
I just want to say that the Board of Pharmacy is engaged on this issue, and that's a really good first step. The second thing I want to say is that we did this study in partnership with 2 very large pharmacist associations. We have connected with a third one, all very invested in this. And so I think we also actually marketed this study, and we had about, I believe, 8 or 9% of pharmacy students completing this survey. So we're going to be able to see some of the results from there. And I think you're right? The education has to change on the front end, and it has to be continuing. So that's definitely starting to happen, and I think that you'll end up seeing much more of these trainings advertised to pharmacists who are already in the field and to the people who are now studying pharmacy. Your comment about starting with a local community is very well taken. We actually are jump-starting with another research study, collaboratives that are regional. So really bringing it down to LA County as one and the Inland Empire as another. Providers and community folks at the table to talk about how to make this pharmacy access real. And a piece of that is that demand piece, right? How do we drive demand so that people are educated, knowledgeable, and are going to pharmacies, but also how do we prepare our pharmacies and our pharmacists to be able to handle that load? So it is something that requires that kind of concerted effort, and we're really excited about the future of that work.
All right, let's go to the last question.
And our last question today is from Kyle Bernier.
Thank you all. Kyle Bernier, pronouns are he and him. Thank you so much for the informative content as well as the work that you all do. Kind of following up on my predecessor's question about education for pharmacists that are currently working. Myself, not a pharmacist by trade, but I do work in the pharmacy space. So what kind of education or programming maybe is to train current pharmacists on SB 159? And then a second question to that is, how do you foresee the introduction of the injectable impacting the policy that's already in place?
I think that the same barriers that exist with the once-a-day PrEP and PEP will continue with the injectable until the access barriers are addressed and education is available to all people that actually need it. I think what we'll see is a similar thing. We can have the best biomedical interventions if people are not aware of them and don't realize how to access them. I think we'll see similar trends. And then the other piece was about training. I think, what I've been impressed with in terms of the city of West Hollywood and their HIV Zero initiative is that when things like this emerge, where we have this new law, they are very responsive in creating programming and new social services contracts to adapt to the needs of the community. And I wouldn't be surprised if something like that emerged in the next or in one of the funding rounds. I can't speak for the city, obviously, but that's what I've noticed, and I think that some training will probably come around.
Board of Pharmacy already has a training program, and the California Pharmacists Association also has one, and they've done the initial trainings to try to get people up to speed. But like I said, when COVID happened, it slowed a lot of things down, and I think these pharmacist associations are going to be our best friends in terms of getting this training out to people in the field already. I forgot the second piece of what you were saying.
The impact of injectables.
Oh, so we actually have a policy paper on that, because injectables actually are much more complicated in some sense than we realize, and in fact might necessitate more visits than pills. So it's a complicated question with some really important policy implications, and we can connect offline so I can share with you our paper.
Okay, thank you so much, all.
Well, I want to give a round of applause to all of you experts one more time, and everyone. The bill is SB 339. It's authored by Senator Scott Wiener. Please call your elected representatives and ask them to vote and support this bill. It is a much-needed fix. It's SB 339. If you live in West Hollywood, you can call Ben Allen. I'll give you his cell phone number. And if you would like to call Rick Zaber, I'll give you his cell phone number too. But nevertheless, I want to thank each of you for giving us a little bit of your time and your advocacy on this really important issue. And thank you, Hernan, and everyone for putting this together. Have a great night, everyone.